Good afternoon to all of you. My name is Annabel Crabb, and I'm delighted that you could join us for the latest Breast Cancer Trials Q&A. Breast Cancer Trials is the largest independent oncology research group in Australia and New Zealand, and they've been conducting clinical trials, research into the treatment and prevention of breast cancer since 1978. Now, we've done a number of these sessions, and they are always illuminating. We attract an audience of people who are undergoing this journey and give them access to some of the finest brains who are hard at work night and day on addressing this cancer that affects so many women. Now, we've had sessions and Q&As on side effects of treatment, on breast cancer recurrence, rare cancers, on sex life and breast cancer. And tonight's is a little less X-rated, but has proven to be one of great interest. Our topic tonight is about treatment optimization. The topic is less is more, rethinking breast cancer treatment. So to those of you, and there are getting on for 2,500 of you who have joined this online session, not to freak any of our participants out, it's a very popular one. We're going to look at this fascinating question and learn a lot from people who spend a lot of time immersing themselves. Our panel of experts, which I'll introduce in a moment, is going to be answering as many of your questions as possible on this important topic and providing an update on the latest in research. But I've got a tiny bit of housekeeping before we get underway. First of all, I'm coming to you from Gadigal land, the land of the great Eora Nation. And I know that there are people joining us from all over Australia and New Zealand. And so I'd like to pay respects to those who have taken care of this land for so many millennia and extend those respects to whomever it is that's been taking care of the piece of land from which you're beaming in this afternoon. Now, technically speaking, and I have to have this written out for me because I'm not a technical expert, if you move your mouse over the screen, in the bottom right-hand corner, you'll see 3 small dots. If you hover your mouse over these dots, you'll see some options. Now, you can click on Ask a Question, or you can make a comment. Now, we have questions already racked up from people who have got in touch already, but all these questions and comments will go through to the BCT team and will not be ignored. So do feel free to keep in touch in that way. You can also, if you have any technical difficulties during the webcast, first of all, try refreshing your browser in the first instance. This is a modernized version of switch it off at the wall and switch it back on. Don't do that. If you're still having issues after that, click info to find the link to access live chat options. But listen, don't panic because you're not going to lose this session. It's being recorded, and in the unlikely event that technical issues arise in our broadcast or you drop off the webcast, we'll be sending a link to everybody tomorrow morning to be able to access the whole event. Oh, I've inserted morning in there. Might not be morning. Don't panic, organisers. It'll be tomorrow. So let's go and get on and meet our panel for this afternoon. A great panel, as ever. We like to include somebody with genuine lived experience, not only of breast cancer, but also of a clinical trial. And Ms. Maragart Lopreiato in Melbourne is with us as our generous participant this afternoon, who is going back over some tough moments in order to help out and share her intel and experience with those of you who are experiencing, I know, uncertainty, confusion, fear, and overwhelm in our viewing audience tonight. So thank you so much, Margaret, for your generosity in being here. Professor Boon Chua, who is a professor of medicine at the University of New South Wales, consultant radiation oncologist, and director of cancer and haematology services at the Prince of Wales Hospital in Sydney. Thank you, Professor. Great to have you with us. We also have Dr. Belinda Kiely. Sorry, Kiely. It is Kiely. Everybody gets that wrong. And now I've got it wrong too, but I won't again. And Belinda is a medical oncologist at Campbelltown and Concord Hospitals in Sydney and specialises in the treatment of breast cancer. And finally, Dr. Michelle Sinclair, who's a psychologist and psycho-oncology researcher who has worked with the Royal Women's and Royal Melbourne Hospitals and is a breast cancer trials clinical fellow. In many of these sessions, we include someone with psychological qualifications because it is a very big part of treating breast cancer. So Welcome, everybody. It's great to have your expertise and life experience with us. There are a lot of people on this Q&A, and I know, as I said, a lot of people in the audience have experienced breast cancer. Others are friends and family who want to learn more about how to support the person that they love who's going through this thing. So thank you to everyone who's sending questions and is watching tonight. I'm going to zero in on you first, Belinda Kiely. I didn't know exactly what this topic meant when I first cracked open the email and thought, oh, what does that mean? So could you start off by laying the foundations for tonight's discussion and explaining what does treatment optimization mean exactly? And can you give us some examples?
Great question. I think what we're really talking about when we say treatment optimization is sort of personalizing a treatment for an individual. So I think traditionally the way we've treated breast cancer has probably been a little bit of a one size fits all model where everybody kind of gets the same treatment. And I think over time, all the sort of people treating breast cancer have kind of realized that breast cancer isn't all the same. Everybody's breast cancer is slightly different. Everybody comes to their breast cancer with their own experience and their own different health problems and different characteristics. And so it's really about making sure that the treatment we're giving an individual is the best treatment for them. So we used to use the word de-escalation, and I think that wasn't a good word because it doesn't always mean less treatment. Some people with a really high risk cancer, we might want to give them more treatment. Someone with a lower risk cancer, we might want to give them less treatment. So optimization is really a good word because it really sort of makes it more of an individually personalized or tailored treatment.
Yeah, de-escalation sort of has that slight vibe to the uneducated, i.e. me, of sort of like, well, we're just going to wind this back a little bit, which isn't what you kind of want, is it, when you're, really trying to tackle this invasive disease? So why are researchers interested in whether a less is more approach is better for some patients? Like, what's driving this investigation, I guess?
I guess one of the big drivers would be the toxicity of treatment. So we have a lot of treatments that work really well. And in Australia, we have really great survival rates with breast cancer. But we also know that a lot of the treatments we use have side effects. And so we don't really want to be giving everybody treatments with side effects if they don't need it. So it's really working out, does someone really need chemotherapy and therefore we're going to give it to them, but the people that don't really need it, we can spare them the side effects and spare them the treatment. So I guess that's one of the big drivers, just trying to minimize unnecessary side effects and ensure people get the right treatment for them.
So I guess typically someone with breast cancer will be seeing different specialists in different fields, I guess, of treatment. Who makes the call? How common is optimized treatment in Australia and New Zealand? And how does it compare to practice overseas?
I guess internationally, there's a big move in recent years to optimize treatment. And so I think most countries are now trying to work out, well, how can we really work out by looking at the details of a cancer, by looking at the person and work out what that treatment should be. And sometimes that does mean we're giving less treatment, and sometimes that means we're escalating or giving more treatment. So I think there's definitely an international trend to this. And I think in Australia, we are sort of up there with the rest of the world doing this. And we have clever people like Boon who's designing studies to optimize radiotherapy. So I think Australia is one of the leaders doing this internationally, which is great to see.
Yeah, and I think we should recognise that Boon's work in particular is now internationally adopted, genuine Aussie superstar. So with the presence of greatness in all of you, of course, but always good to see Australian expertise being shared across the world, as it is so often. I wonder if you could just, you talked about side effects earlier, and is the main game of optimized treatment to minimize side effects, or does it have a clinical merit as well?
I guess the main thing is we don't want to compromise the sort of cure rates. And I guess that's the big thing. So it's trying to do it safely. Yeah. So yes, I could sort of not give anyone chemotherapy, but I know there's people that are not going to do as well without it. So they need to get it. So I guess the big thing in Australia, and this is what Australia is very good at, is making sure that any of these optimized treatments we do are evidence-based. So we want to make sure it's been proven to be safe to give less treatment. We want to make sure it's safe to give more treatment. So I guess it's trying to maintain or improve our already very good cure rates, but trying to do it in a way where there's less toxicity.
So breast cancer trials is, a huge practitioner of these trials that really do drive a lot of the advances in treatment of breast cancer and are responsible for the radically improved survival rates for breast cancer over the last 2 decades. It's quite phenomenal in this country. And in order for those trials to produce the kind of intelligence that you all need as researchers and as practitioners, you also need human beings with breast cancer to participate in them. And so I think I just bring in Maragart here, who is one of these heroic people who, puts their own body in the interest of science and can yield some intelligence and advances for patients, other patients as well as themselves. I wonder, Maragart, if you wouldn't mind, whether you could start by just telling us the basics of when you were diagnosed with breast cancer and how you found out.
I was diagnosed with breast cancer in 2013. I was around 50 years old by then. I just had a routine mammogram, and I didn't feel anything. But they picked up there was a lump. Then I was referred to get a biopsy, and they confirmed it was stage 2 breast cancer, and it was also hormone positive and HER2 positive. That's when I had a biopsy, and I went to a surgeon. He removed the lump, and then I had to have chemotherapy, so I had to see an oncologist, and I had regular checkups, and I never had radiotherapy, which was good. And it's been 11 years now, 3.
How many years did you say?
11 years now.
Oh, that's incredible. Well, that's a great outcome for you, Maragart. I wonder, in the old days, everybody would get mastectomies just sort of straight away, wouldn't they? And obviously that is not something that is widespread anymore. I wonder, you did have chemo, you didn't have radio. What side effects, if any, did you experience from treatment?
A bit of brain fog, a little bit of nausea and fatigue, and that was it. Yep. But when I had chemotherapy, I started on a Monday and I finished, and I had the week off of work, and I still kept on going. So the week after, I went back straight to work.
Wow.
I felt all right.
Wow. You are a tough cookie. Okay, so at what point did you commence your participation in a trial? Because you were in a trial called PROSPECT, weren't you, which was aimed at identifying patients who might be able to safely avoid having radiotherapy. Okay, so what was the decision like to participate in that trial for you?
I wanted to do it because when I heard about the trial and I didn't have to do radiotherapy, that was mine, and my mind was clear that I didn't have to do it. I just felt comfortable, like it was bad enough having chemo.
Yeah. So how do you feel subsequently after having been in the trial? Obviously this is a really unfolding area of medicine, and you've been a part of actually providing the intel for driving it. Feels good, I guess.
It was good because I looked after me really well. I kept having mammograms to check, not mammograms, MRIs.
Yep.
And it was great.
Well, thank you, Maragart. Thank you for A, participating, but B, sharing your story with us. I guess that what I hear over and over again in these sessions is that for people who are closely post-diagnosis, it's like a world of information that they don't know yet. And so that terror of not having all the information at your fingertips can cause you to panic a bit and sort of try everything. And I guess what we're talking about tonight is a concerted clinical attempt to be more targeted and to spare people the sorts of side effects that they might experience from being microwave from the inside out. That image is never going to leave my brain. So I'm going to we're about to have a talk to Boon, and I'm going to introduce her by running a video that's about another clinical trial, which is called the EXPERT clinical trial. It's a study developed by Australian researchers.
Breast radiation is generally a safe and effective treatment. However, it does have some side effects. There's also a very small risk that radiation itself could increase the risk of another cancer. The EXPERT study aims to test a genomic assay whether it could reliably identify patients with low-risk early breast cancer who may safely omit radiation and associated side effects. Radiotherapy is very resource-intensive treatment. If we could spare patients who would not benefit or would benefit very little from such a treatment, then we'd be in a position to better target the use of the precious radiotherapy resources to those who really need it. The EXPERT study may be suitable for patients with subtype of breast cancer known as the luminal A breast cancer, which typically is associated with low risk of recurrence. A number of patients have already been recruited to study, and we're also working very hard with our international colleagues around the world to open the study worldwide.
Okay, thanks, Boon. I welcome you to the hot seat now. Boon, you're the study chair of EXPERT. Can you tell us how the idea of this particular trial came about? Oh, I think you might be on mute. 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 Okay, give it another shot.
Yeah, good.
Great, thank you.
We've known for many years now that radiotherapy after surgery is effective in decreasing the risk of cancer recurrence, and as a result, it is a standard of care for many patients with early breast cancer. However, we have also heard from Belinda that no two breast cancers are the same, and therefore the benefit of radiotherapy in each individual patient does vary, sometimes quite substantially. In addition, over the years, the recurrence rates pleasingly have been falling due to advances in multidisciplinary breast cancer care, not just limited to the advances in radiotherapy, but also in the quality of breast imaging, the surgery and the pathology assessment, and also, of course, the improved efficacy of the systemic therapy, including chemotherapy, endocrine therapy, etc. And therefore, I think the scene is set that a priority in contemporary breast cancer care is to tailor the use of radiotherapy to the recurrence risk of the individual patients. And we may be able to do so by identifying patients with low risk or very low risk of breast cancer that is unlikely to benefit from radiotherapy, and therefore supporting these patients in their ability to avoid overtreatment. And we know that overtreatment does come at a price in terms of unnecessary treatment toxicity, the financial costs in some patients, and logistical challenges, especially for our patients who live in the more remote parts of the country. And over the years, there have been a number of clinical trials that have been published, and they tested whether there is a reliable way, an accurate way of identifying these low-risk patients based on what we consider conventional pathology. Some were successful, but these trials haven't been consistently successful. And in more recent years, we've also learned that a new technology known as the multi-gene expression assay, it could identify different breast cancer subtypes, which would have distinct clinical outcomes for each of these subtypes. And therefore, this forms the basis of the EXPERT trial. And we aim to use this multi-gene expression assay to more precisely quantify the risk of cancer recurrence in the individual patients and help to identify patients with low-risk breast cancer who may be able to safely omit radiotherapy after the surgery.
Okay. I wonder if you could tell us a bit more about how specifically you identify whether a patient could potentially have less treatment and still have the best possible care in the treatment of their disease.
Well, I think it's important to have that conversation with the patient about a treatment option that would best fit their preferences and their values. I mean, if you look at the current generation of clinical trials, quite a number of these trials are testing the use of these genome analysis or multi-gene expression assays to improve the precision of prognostication, meaning that using these assays to assess the activity of these individual cancers, and therefore we may be in a better position to predict the risk of recurrence in these particular patients. And it is important to understand that these estimations, they are numbers, and it is important to use these estimations in the right context to support the patients and the clinicians in coming to a decision whether they have radiotherapy or chemotherapy or not. And we need to take into account not just this risk of recurrence, but also what the patient's preferences are, and also take into account a range of other factors such as their age, the tumor size, and etc., and tumor grade, etc., etc.
Okay, so what would you, I mean, and congratulations, by the way, on your success in this research, which, as with much of your work, has been of benefit internationally. What would you like to see come out of this research? What is your dream result?
I think, firstly, I should say that the expert study, it won't be possible without the support of the breast cancer trials, and also with the support of the Breast International Group that is based in Belgium. And also all credit to our entire national and international team. This is absolutely very much a team effort. Now, as for me personally, what would I like to see out of expert? And I would like expert to be able to generate that critical evidence that is required to set the future standard of care in personalizing treatment for patients with early breast cancer to avoid unnecessary over or under treatment. And I also think that efforts to optimize care, as you say, it needs to be tested rigorously in a clinical trial setting to support a balanced and informed decision by the patient and also by the clinician, so that we don't compromise patient outcomes either individually or collectively. And also, I think it's also important to understand that integral to this treatment optimization is a clear understanding of the issues that matter to our patients, including constructs such as the fear of recurrence and the convenience of care. And I hope that the expert study will be able to provide the novel data to support this shared decision-making.
Thank you so much, Boon. I think, yeah, I mean, all of this seems to be about customizing information, making yourself as familiar as possible with each patient's circumstance, their kind of cancer, and all the other factors that allow a dedicated and personalized treatment that avoids unnecessary pain and suffering, even though the instinct of the patient may be, I want everything, and certainly it used to be a more common approach. I'm just going to show you another video now. This is about another trial which has recently opened called OPTIMA. These trials all sound a bit like really cool car names. I mean, they're much better names than the ones that we give to tropical cyclones in this country, but let's hear about the OPTIMA trial.
Traditionally, with breast cancer, the way we treat it is often with chemotherapy and hormone blocking tablets. But we know that we often are giving chemotherapy to women who don't get a benefit from it. So what OPTIMA is trying to do is to see whether a test on someone's breast cancer tumour can work out whether they might be able to do just as well without having to receive chemotherapy. I'm Dr. Belinda Kiely. I'm a medical oncologist based in Sydney. specialising in the treatment of breast cancer, and I'm also the study chair for the OPTIMA clinical trial. So the OPTIMA trial is looking at men and women who have been diagnosed with early stage breast cancer, who have got either positive lymph nodes or a large sized cancer with lymph nodes that are negative. They need to be aged 40 or over. The cancer needs to be hormone receptor positive and HER2 negative, and it needs to be someone who is fit enough to have chemotherapy. What we really are doing with de-escalation is reducing treatment but not compromising outcomes. So it's giving less treatment but getting the same outcome. So I've been working in breast cancer for many years now, and I see the side effects of chemotherapy, and I see people coming in and hoping that they don't need to have chemotherapy. So it'd be really nice if I could give someone chemotherapy and know that they're actually going to benefit, and it would be really good if I can say to someone, actually for your cancer, we don't think the chemotherapy is going to add any extra benefit. So it's going to be really exciting if this test shows that we can find those cancers that can safely avoid chemotherapy.
Well, thank you, video Belinda. We now turn to real life Belinda. This is like interviewing people after the Academy Awards. Look, a number of people watching have said that, you know, in their feedback that they love the idea of less treatment, but when push comes to shove at the time of going through breast cancer, their mindset at the time was, give me everything you got. I want to get rid of this disease. How do you approach a conversation with a patient and explain that we'd like to give you less treatment and we believe that this will give you the same outcomes?
It's challenging. I think this study is a hard one, and I think that a lot of people will sort of struggle with that whole idea because, yes, they come in and they say, give me everything. So I think the type of breast cancer that this study is for is hormone positive, HER2 negative. It's the most common type of breast cancer. Yep. And what we know is that the most important treatment for most people with hormone positive breast cancer is actually hormone blocking therapy. And so I guess I'd be starting by saying exactly that the most important treatment you need is hormone blocking tablets. And we know they are really effective in reducing the risk of the cancer returning. And we know that really only a small number of people need chemotherapy as well. But at the moment, we don't really have a good way of working out who those people are. These tests that they're doing in the study have been used for many years now in low-risk cancers, and they have shown that it does look like they can work out a population of people who are going to do really well without chemotherapy. And so I guess in the OPTIMA study, they're now trying to see, can we use those tests in people with higher risk cancers to see if we can also safely identify a group that don't need chemotherapy.
Okay, so tell us a bit more about these tests that you use to help identify patients who may not need to have chemotherapy. How do they work, and are they becoming more common to tailor treatment?
Yes, so there's several of these tests. So the one that's been used in the OPTIMA trial is called ProSigna, but there's a few others. There's one called an Oncotype, there's one called an EndoPredict. And what they essentially do is it's kind of it's like a machine does a test on the actual cancer tissue. So people coming in don't need to go and have another procedure or a biopsy. We actually use a sample of their cancer that's been removed at surgery already. And that sample's in the lab. So we use that sample and it gets sent to a lab. So this test is being done in Australia, in Queensland, this lab's doing the test. And they have a machine that looks at, for the ProSigna test, they look at 50 different genes in that cancer, sort of detail that we can't look at normally. So I can sort of look at how big a cancer is, how many lymph nodes are involved, but I can't look at the sort of details of the genetic makeup. And it's those genes that really then can say, this looks like a really nasty high-risk cancer, and therefore this is someone who really does need chemotherapy, or this cancer looks like it's behaving a lot better, and probably if it just has hormone blocking tablets, they're going to do really well. They don't need chemotherapy as well. So the ProSigna is the test used in this study, but those other tests are all available in Australia, but they're not available free. So in Australia, patients have to pay to get those tests. So I guess in the study, they don't have to pay for this test. And these tests are used internationally. So a lot of other countries actually do have these tests available without cost to patients with lower risk cancers. Australia hasn't done that yet because I think in our sort of setting, we want to make sure these tests are safe before the government funds them. And so we're hoping this study will actually prove that doing one of these tests is a safe thing to do. And that will then sort of help us hopefully encourage the government in Australia to fund one of these tests.
That's an important point you make there, Belinda. I think like some participants in these trials can have access to resources that they may not be able to afford themselves. And the therapeutic value of that is considerable. I also will just remind everybody watching that these trials are not cheap to run, and if you do feel minded to support the work of breast cancer trials, you can do that through the website. I know that there are many grateful families who have benefited from the work and research undertaken by breast cancer trials in the years since 1978, when it all started. Just a question for you before I move on, Belinda. You talk about testing whether a cancer is a well-behaved or a less well-behaved cancer. Is it a rule of thumb generally that could be concluded from our viewing audience that if the nastier your cancer is, the less likely you are to be able to like swerve chemotherapy? Is that a reasonable assumption? I know that all of the types of cancer, like it's like a sort of multi-directional, matrix. So it sounds like a dumb question, but I ask it anyway because I know I'm allowed to.
Yeah, so what these tests are doing is sort of trying to pull out with the sort of genes who those sort of bad player cancers are. And yes, they are the ones that we think have got a higher risk of returning, and they're the ones we want to make sure get all the treatment. So they're the ones that we think are going to need chemotherapy as well as hormone blocking tablets. The other thing with this OPTIMA trial is Australia has started opened this study only in January this year, but the study has actually been running in the UK since 2017. So it's been going for a long time. And so there's actually over 4,000 people on this study now internationally. So in a way, I guess that's a good thing for Australia coming on late because it's kind of been tested in the UK. So those patients in the UK have sort of gone on this study, and if they were seeing sort of dangerous problems, like it wasn't safe to do this, the study would have been stopped. So now that we're kind of 7 years down the track and it's still going, it is looking like there's no sort of safety signals. So I think that's another reassuring thing for people in Australia looking at this study, that it has sort of been tested in over 4,000 people in the UK already.
Great. Okay. Thank you. That's very enlightening. And obviously when people are making decisions in the thick of it about what kind of treatment they want to be having, when they're looking for information, it's a stressful series of decisions to make. It is confusing. You're not at your best psychologically because you're feeling overwhelmed and frightened, and you're looking after people around you as well as being looked after by them. I want to bring in Ms. Michelle Sinclair here. Michelle, as a psychologist, you've been doing research into the fear of breast cancer recurrence, right? And I know from previous sessions that this is, it's kind of an unceasing worry that can really occupy people's brains even well after the event. We hear about scanxiety and people going in for their regular scans and feeling that fear. How prevalent is the fear of breast cancer coming back among women, and what are the symptoms and scales of that fear?
Yeah, so when we're talking about fear of cancer recurrence, we're referring to those very concerned thoughts, worries, and anxieties about the possibility that the cancer will come back or that it will progress. And that can be worries about it coming back in the breast or somewhere else in the body. But having these thoughts or concerns are a very valid and normal and even expected response to being diagnosed and treated for cancer. So I want to highlight that it's very expected. A cancer recurrence is a legitimate threat, and so it makes sense that women are concerned about it happening. But when we're talking about how prevalent it is, it's very common. Most patients will experience some level or some worries about the fear of cancer coming back. However, for between 60 to almost 90% of breast cancer patients, they'll experience heightened level of fear. And this is where the fear is likely having some impact on their life. And for about 20% of patients, these concerns become quite problematic. And when I say problematic, I'm referring to the frequency, the duration, and impact that this worry has on a patient. And this can take the form of constant intrusive thoughts about the cancer that are hard to control, constant scanning for symptoms of recurrence, or a misinterpretation of mild unrelated symptoms as signs of recurrence, and difficulties making plans for the future due to these worries. And I guess often fear and anxiety, we just want to get rid of it. It's very uncomfortable, but it's actually in itself not a bad thing. We don't want to get rid of it. It helps us to be aware of threats, and at normal levels can motivate us to respond appropriately. So in this context, it can help patients to maintain healthy behaviours and appropriate awareness. But it's when these fears start to have a negative impact on patients' ability to have a meaningful life that it starts to, we want to perhaps have some intervention around this, and intervention's likely to be beneficial. So we know that there are peak times when fears are more likely to be triggered. So patients often tell us, or we observe soon after diagnosis, there's a spike, and at the end of treatment, when the structured support and frequency of contact with clinicians tends to drop away. And also you mentioned, Annabel, like around scans, so the scan anxiety is very common. But outside of these fluctuations, levels of fear of cancer recurrence, they tend to be fairly stable. And so that means that if early on in the cancer journey, their fear is quite high or it's quite problematic, it's likely to stay high and not resolve without intervention. And this is where I'd highly encourage patients to get professional help soon, and it's likely to be beneficial. Because
it actually can be helped, can't it? I mean, it's not just a question of this is what your life is like now. So it is a constantly evolving journey, and no one listening should think this is just my new state of mind now. Constant worry, because it is possible to reduce and contextualize the load of that anxiety, particularly if you're carrying, I think, the anxiety of others, children, relatives, people that you have a kind of obligation to nurture, as well as those who are trying to nurture you through a difficult experience. Now, some of you in the in the viewing audience may be thinking, why is Annabel suddenly asking Michelle about breast cancer recurrence? It feels like a change of subject. It isn't, because you undertook some research into the association between optimised treatment and fear of recurrence. Now, before I ask you to outline the findings of that research, I want to know what led you to pursue this connection.
So I think that in particular, fear of cancer recurrence is a very specific anxiety. And when we're looking at it, it doesn't necessarily relate to the level of, or to the rate of recurrence, the risk of recurrence that patients may have. And so it can also have such a significant impact on patients, as you highlighted, for years in post-diagnosis. So anything that's likely to impact patients' quality of life and that is treatment related, then I think that's worthy of exploration. And yeah, so I'll leave that there.
Okay, so well, tell us about the result of this research, I guess. What did you find out about the interconnection between optimised treatment and fear of recurrence?
So the trial that Margaret was involved in, actually, PROSPECT, used MRI and pathological findings to select women who were suitable for not receiving radiation, so radiotherapy emission. And following on from PROSPECT, we were interested to know if the impact of that emission of radiotherapy, what it was on fear of cancer recurrence. So if patients don't receive radiotherapy, do they have more fear if they're receiving less treatment? And we invited women in Prospect to complete some questionnaires about their quality of life and their fear of cancer recurrence. We also interviewed some of those women. And then we also invited women who had usual care, including radiotherapy, to complete the same assessments. We had a lot of data and from over 400 women, and we also had 20 hours of interviews. And I could go on about this, but I'll summarize the key points. For all groups, patients reported that they understood their treatment plan was recommended and tailored to their cancer, and it was appropriate. And this was seen as very protective against their fears. But when we compared the groups, so those who did have radiotherapy and those that did not, we found that women who were eligible for radiotherapy admission, so they avoided radiotherapy, they believed they had made the right choice. They had much lower levels of fear and fewer side effects, including better quality of life, than both groups of women who received radiotherapy. So avoiding radiation was associated with less fear. More treatment did not mean less fear.
Gosh, that's so interesting, isn't it? I mean, I guess, you know, we talked a minute ago about the old days where everybody would have a mastectomy and then have everything thrown at them. And I guess that might, you know, Dr. Crabb here, fully qualified psychologist, you know, that might contribute to a feeling of powerlessness and lack of agency, which makes you feel like you could be the victim of a, you know, a completely, you know, a set of circumstances or a recurrence that's totally outside your control. Is it possible that when people feel like they understand more about their treatment and understand about the specific decisions that are made that are tailored to their case, that they feel a bit more like they have agency?
Yeah, so we looked at that because it was quite unexpected. And we looked at the interview data and what women were telling us about their treatment experiences. And so we believe there are two things that really contributed to this. So first, like you highlighted or what you hypothesized there, being assessed as eligible for radiotherapy admission in combination with the communication from their treatment team that their cancer was caught early was an indication of lower severity of disease. And so patients believed that they were lower at risk because they were. But also secondary, we found that for women who did receive radiation therapy, and my mind was brought to this when Margaret commented, which I'll come back to, recalling the experience of treatment itself and the ongoing side effects of treatment, particularly breast symptoms, served as a reminder of cancer and possible trigger for fear for these women into survivorship. So Margaret mentioned cooked from the inside, this idea of that's what radiotherapy was going to be like. And some of the women told us that that was their experience. And so this served as for these women as a trigger for fear into the future. So it's not necessarily that less treatment equates more fear. There are other things to consider.
Okay, and I will remind those of you who are watching this session and are due to have radiation, this is Margaret's words, she hasn't had it. So like, I'm sure that you are best advised to listen to your oncologist and to your treating physicians to what you need to look out for and precautions to make your experience of your treatment as peaceful and well-informed as possible. Margaret, given that we have a two-time guinea pig with us, Margaret, who's not only been in the PROSPECT trial, but then doubled down to be useful to Michelle in her, I think, you know, they're remarkably interesting findings from those interview studies. I just want to know, I guess, listening to the results of Michelle's project, does that kind of gel with your experience of having had an informed choice to have less treatment?
Yes, it did. I believe it made the right choice, and I trusted the doctors and the specific treatment plan. And I agree, I had less fear.
And you felt that, I guess, that your treatment had been tailored to you, and that you were also, I guess, benefiting from all the expertise that was being poured to this trial as well. How much, tell me if this is too nosy, but how much do you worry about your breast cancer coming back? It's been quite some time now. Have you noticed any change in that fear, in the scanxiety that
I think everyone's is going to be worried about it coming back. But if you have your mammogram every year and talk to your doctor, if you feel like you've got something's wrong, you go to your doctor and sort it all out.
And do you feel like, I mean, I know that one of the anxieties that women have in the years after they're cancer free, they feel like that anxiety about, oh, should I go to the doctor? Am I making too much of a fuss about something tiny? Do you feel like that, or are you kind of like, right, let's march off, check this out?
No, I would just go and check it out. Yeah.
A very great policy. I think Michelle is just waving to make a contribution. Michelle?
I did just want to add that certainly wasn't everybody's experience of radiation therapy. And I did want to really clarify that a vast majority, as I said at the beginning, their treatment was appropriate for them, and that was really great, and they were grateful for the treatment they experienced. So while I did highlight that point, it's not an across-the-board experience.
Well, I guess, I mean, I have some close friends and family who've had radio that, that is not a form of words that would really apply to their experience. But the truth is that also, just as there are so many different kinds of breast cancer, there are all sorts of different kinds of people who have it and who respond in different ways to all of the therapies that can be brought to bear. So I guess that's all part of this sort of giant puzzle that you're all trying to put together. I'm going to direct some questions back to Belinda now. There's been such an interest in this topic, and many of you watching have submitted a question to the panel. So I'm going to throw a few at our experts, starting with you, Belinda. Robin has asked, how can you be certain that a less is more approach is best overall when so many women have recurrences at 5 to 20 years after the original diagnosis?
A good question. I think, look, you can't be certain. I guess we know treating breast cancer, there's no guarantees with anything. So what we're trying to do is, I guess, just try and work out which cancers we think can safely be spared chemotherapy and do just as well with less treatment. So I guess we're doing it in the setting of a clinical trial. So we are not just sort of doing it to see what happens. We're going to be doing it in a trial setting. We're comparing it to the standard treatment currently, and we're doing it on a very select group of people. So again, it's not one size fits all. It's the people that have got the hormone positive cancer, it's HER2 negative, they do this extra ProSigna test, and the ProSigna test comes back saying they've got a low risk. They're the ones that we're going to try and not give chemotherapy to. So I guess it's just the way that we're doing this. We're sort of selecting out a group of people that we think are going to do well just with the hormone blocking tablets. So it's certainly not saying no one needs chemotherapy now. It's just there's a group of people that we don't think need it, and we're trying to identify who they are. How do we know if this is going to work? Well, this trial is going to have to be followed up. So they're going to recruit 5,000 women to this study, and then they're going to follow those women up to make sure that they don't have a higher risk or a significantly higher risk of the cancer returning. And then we're going to know that actually doing this test was safe. So we don't actually know that at the moment. We think, based on the studies that have happened so far with similar tests, that we think this is going to be a safe approach, but until we get the follow-up on this study, we don't know that for certain. So it does need people who are going to be brave like Margaret, I guess, to sort of do these studies and sort of try and see whether we can prove that this is a good way of changing the treatment pathway for the future.
I just wanted to, this is a question from me that I'm just throwing in at you, sorry about the zero notice, but I was wondering, like, how prevalent is this sort of response among patients that you see who are kind of like, no, I want everything. Just chuck it all at me.
Yeah, I think it's very different. Like I'm saying that breast cancer is all different. People are all different. And so you'll have someone come in and I'll say to them, look, I think you should have chemotherapy. And I say to them that I think the benefit of the treatment is it's going to reduce the risk of recurrence by 5%. Now you'll have someone who will say, well, I'll do it even if the benefit's only 1%. I want to do everything possible, give it to me. And then I'll have someone else who hears that same 5% and they'll say, 5%, that's nothing. I'm not going to lose my hair and do all that treatment just for 5%. I need a bigger benefit to make it worthwhile. So it's interesting. I think everybody sort of thinks about these things differently. And so I think we have to allow individuals to make that decision. So we kind of give them, these are the risks, these are the benefits, and then they sort of make up their mind based on their own experiences that they come to sort of this journey with. So I think, yeah, you certainly have the people that say, give me everything possible. And then you have the ones that are like, no way, I don't want that unless it's a big benefit.
Yeah, I think that's such an important point. I'm really glad that you've made it. Belinda, I also think, there's, I guess, is it true that there's no such thing as an incorrect response to this sort of question, right?
Yeah, no, I think so. I think that I think it's always, I think everybody's just so different in how they come to this and the decisions they make. And we're sort of there to try and help them make the right decision. But at the end of the day, each person has to make the decision that's right for them. And so I think that these conversations can be very, very long and very challenging, and often it takes people a long time to make a decision. Others will come in and they know straight away what they want. And so I think it's one of the good things about the job, I guess. You see a lot of different people and you sort of have these conversations and you help them make what's right for them, the right decision. And
I guess people make different and better decisions the more information they have about what's going on in their bodies, and that's always a good thing. Look, while I've got you, Belinda, there's a bunch of questions coming in during the broadcast, which is, why is Australia doing these trials if there have been trials done overseas?
Yeah, another great question coming from the audience. So the studies that have happened overseas with these tests have been essentially in women who have got lymph node negative cancer. Okay. So they've shown in the lymph node negative cancers that doing one of these tests, if it comes back low risk, you can pretty much be safely spared chemotherapy. So the idea of the OPTIMA trial is now to extend that into a higher risk group. So what OPTIMA is doing is looking at women who have got lymph node positive breast cancer and testing whether this test can select out a group with lymph node positive cancer that can be spared chemotherapy. That really hasn't been answered yet in the other studies that have been done overseas. So I think those other studies have sort of helped OPTIMA happen because it's given us some assurance that it looks like it's going to work, but we're now sort of extending it into a slightly higher risk group of people. So that's the important reason why we need to do the OPTIMA trial.
Great. Okay. Thank you. That's a great answer. And I'll just, one more question from one of our participants. Her name's Andrea. And she's asked, how does the principle of less is more apply to those with metastatic breast cancer?
Similarly, I think with metastatic breast cancer, survival rates have improved dramatically because of improvements in treatment, particularly. So the treatments we give now, people are very often living many years with metastatic breast cancer. So I think one of the priorities when people are living for many years is to help them live those years as well as possible with as few side effects as possible. And so for a long time, I guess the approach for metastatic breast cancer is to try and use therapies sequentially. So we'll often use one treatment, then another treatment, and try and minimize the side effects. So we sort of don't often use like combinations of treatment altogether, which we're probably more likely to do in the earlier breast cancer setting. So I think we probably have been a little bit better maybe at sort of optimizing treatment for metastatic breast cancer in that sense for a while. But then at the same time, there is a lot more now going on with sort of genomic testing and things where they can test tumors and again work out more targeted treatments. And again, there's a bit of a move away from chemotherapy to more targeted therapies, which often have less side effects.
Okay. Thank you, Belinda. I'm going to swivel back to Boon now because we've got a few questions that have come through that are very relevant to her. I'll start with one from Karen, who's asked, how can we be sure that all cancer cells have been removed without having radiotherapy? Oh, I think you're on mute again. Boon, unmute, please.
My apologies.
Not at all.
This is a good question that I've been asked many times by my own patients. Many of these patients would have surgery upfront, and surgery would remove the bulk of the cancer. And therefore, the purpose of giving radiation after surgery is to eradicate as many of these remaining microscopic cancer cells as is possible. There is no test that can show whether there are any residual microscopic cancer cells after surgery or radiotherapy for that matter. However, we do know from all these clinical trials that have tested omission radiotherapy in carefully selected patients with early breast cancer. And these trials have shown that over 90% of patients who didn't have radiotherapy did not have a recurrence after 10 years or more of follow-up. And what these findings would suggest is that many of these carefully selected patients with early breast cancer would derive a meaningful benefit from radiotherapy. And the challenge for us as clinicians is to find out ways to improve the precision of selecting these patients with low risk or very low risk cancer who will benefit from radiotherapy and therefore be able to avoid the over-treatment. And that is the very goal of the expert study.
Right. Okay. So I'm going to follow up with a question from Therese, which I'm sure would be one that would be foremost in some of our listeners and our watchers' minds. She wants to know that if patients receive more surveillance, more monitoring, if they have less invasive treatments or less treatment.
Yeah, I don't think there is a right answer necessarily for every patient. I think the intensity of surveillance, as in the number of tests, the frequency of tests, mammogram, for example, I think that is a decision that should be made between the patient and the clinician to work a way that both the clinician and patient think will be appropriate for the particular patients. As for the expert study participants, these patients are highly selected patients based on their tumor pathology, but also based on the genomic test. And in expert study, half of these patients will receive no radiotherapy, but they will all receive hormonal therapy. And the surveillance in this study is comparable, I would say, to many patients who receive radiotherapy in the day-to-day practice.
Okay. We just heard from Belinda about, different types of breast cancer and their expanding focus in clinical trials. Louise has asked if there is research happening in optimized treatment for all stages and types of breast cancer, such as triple-negative breast cancer.
Yes, I think the concept of treatment optimization really applies to patients with breast cancer of all stages and all subtypes, and they're not limited to any stage or subtype per se. And optimization, as Belinda has said, it doesn't always mean less treatment. In some patients, it may mean more treatment or different type of treatment. And the aim of optimization really is to tailor the treatment that a patient receives to their risk of recurrence. And in expert study, for example, the expert study aims to enroll patients with stage 1 breast cancer of the lumina A subtype, which usually has the best prognosis. However, there's also active research testing other breast cancer subtypes, for example, whether radiotherapy is necessary for patients with triple negative or HER2 positive breast cancer that has responded completely to systemic therapy.
Okay, thank you for that clarification. I think it's important to keep what you've said in mind, that optimization doesn't necessarily mean always doing less. Sometimes it means doing more. It means just doing the things that are the most useful, I guess, and the most intuitive for the individual, for the way the individual, for the kind of cancer that the individual has, and also for the kind of person that the individual is, which kind of neatly brings me back to Michelle. We've got a question in from Patricia, Michelle, who asks, how do you reconcile doing less, if that's what the optimized treatment involves, when the fear of recurrence makes you feel like you should have done more?
Yeah, a really good question. And I think there's a real language in cancer care around the fight. And when it comes to cancer, it's been mentioned a few times, I'm going to beat this, I'm going to throw everything you have at it. And this can be motivating and gives us a sense of control at the time when we're so filled with uncertainty. And to be told there's a recommendation or an option to receive less treatment is a bit confusing, I think. If you're fighting something, aren't you going to throw everything you have at it? And so what does that mean? Which is a very reasonable response. And as Belinda highlighted, clinicians want to ensure that patients make the best decision for them. And that really varies. They're balancing the preferences with the optimization of the treatment and trying to provide the maximum benefits that aren't causing unnecessary side effects. And so with PROSPECT, in our follow-up study, what we saw was that more treatment does not necessarily mean less fear. And in that study didn't mean less fear. So it can become about making an informed treatment choice that's right for the patient, and then tolerating the uncertainty, finding ways to manage the fears and concerns so that they don't get in the way of what's meaningful for the patient. And cancer can take away that sense of control that we have over our lives. And so ways to get back that sense of control to start with is a great way to start. So understanding personal risk and what that means, understanding what's normal and expected with regards to side effects and what would warrant further investigations. And then when it comes to the fears themselves, anxiety likes to be a bit ambiguous and loom in our mind. But when we clarify what it is that we're actually anxious about and talk with a trusted friend or get those thoughts out, sometimes through journaling, this can actually be very helpful. A lot of the treatments for fear of cancer recurrence also revolve around shifting the focus and reframing your attention to a more present focus, saying it's all about what's going to go wrong in the future. I'd also like to mention some resources, like Breast Cancer Trials website has a Q&A on fear of cancer recurrence, which has some great tips in there. And also the BCNA has some great resources, including videos on managing fear of cancer recurrence, including some strategies, which I highly recommend patients look at. They also have a telephone support line.
Great, that's awesome info. Before I all right, hang on a minute. I can see Belinda's waving finger in there.
I just one quick thing I wanted to add to that question we had from Patricia, I think, is that sometimes doing more doesn't always reduce the risk of recurrence. And I guess that's what people sort of think, give me everything you have, and they think if they have everything possible, the cancer will never return. But unfortunately, that's not always the case. The cancer can still return. Even the people that have all the chemotherapy and the radiotherapy can just be really unlucky that they've got a cancer that still does come back. Now, that's a low risk, but I think that what we're sort of doing in these studies is we're saying, look, we don't think if you have the chemotherapy, your risk is going to be any less. So I guess we're sort of picking out people where we think their risk is as low as possible with the hormone tablets, and giving them extra treatment probably won't change that. So having more treatment doesn't always reduce your risk of a cancer returning.
This is a question of mine, and I'd be interested in hearing Belinda and Michelle's views on it. We've got a minute or two of space in the schedule. This idea that you raised, Michelle, of this language that we use around cancer being a fight, and you've got to be a fighter, and there's this sort of heroic element to the idea of an individual riding into battle with this disease that kind of obviously it creates a sense of, well, I need as many weapons as possible on my holster or whatever. But also it does, I know, make a lot of people feel that if they don't feel courageous and if they don't feel fearless and if they don't feel like they're, you know, ready to duke it up with this disease, they feel like they're not doing a good job. I mean, how often do you see that? And how, and that's a question for you, Belinda, and also Michelle, like how do you reframe that language?
I can start and just say I really hate that language. And I think the other part of it is that you've lost. Like if your cancer comes back or you die from your cancer, you're the loser. You lost your battle. And I hate that language because you didn't lose. I mean, you did everything possible and you just had a bad cancer and it was probably just bad luck. And I mean, I think we really do need to reframe it. And I think, unfortunately, the media doesn't help because every time there's a story about breast cancer, it's about they fought the battle and they lost the battle. And I don't know whether you've got some wise words, Michelle, on how we can help with this.
Oh, look, I think it's quite nuanced in it. It is so common, and the language kind of traps you into believing that if you're not heroically going in and motivated, and that's just not the treatment experience for so many women. And so then, yeah, just as you highlighted, what happens when there is a recurrence? What does that mean? Did you not fight hard enough? And so it's really quite unfair on patients. And so I think that when we're looking at this, it's about being a bit more realistic on what this is. And it's not a if you fight hard enough aspect. It's we're going to do the best we can while we're tolerating this, and you're making treatment decisions on evidence-based, but there's a lot of ambiguity and a lot of uncertainty, and that's uncomfortable. So we're often looking for certainty. If I throw everything, I know I've thrown everything at it and I've done everything I can. But that doesn't necessarily mean that you're going to have better outcomes. So if we can learn ways to better understand what's going on, talk about these concerns, and tolerate the uncertainty, then we're going to have a better journey understanding and not have to fight these external pressures as well as undergoing cancer treatment at the same time.
Yeah, I think, Michelle, just to finish off with you on this section, I think, you know, there's, we're talking here about clinical treatment, but of course, if you have breast cancer, you're also on the internet, you're also getting messages from people who tell you about their friend that, you know, gave up orange food or something and recovered, or like, you know, everybody's got a story. And so you start to feel, and I know for a lot of women going through breast cancer and other cancers, they read things about fitness and exercise and diet and all of this stuff, and then beat themselves up when they, you know, have some chocolate or whatever, you know. Like there's so many triggers to feel bad about how you're coping or what you're doing, and it kind of it comes in waves over the course of your treatment, doesn't it, where you feel more vulnerable at some bits than others. Yeah,
and so these concerns are often triggered by mentions in the media or hearing about someone who's been diagnosed, or seeing the little pink lady or the ribbon on a loaf of bread. And so when coping with that, sometimes it might mean that you find ways to go on a media diet. So not necessarily blocking out all media, but it might mean that you're being more aware or direct in your consuming of that, if this is particularly triggering for you. And other areas as well, when you're talking about these sorts of things, finding those people in your life who you find the conversation is helpful for you. If someone's coming and they're quite invalidating and saying, well, why are you worrying about that? Or just think on the bright side, that's really unhelpful and invalidating. It's really concerning. So for patients, and so finding those people that it can be really helpful, or all the ones who really build you up and can listen to your concerns. If the fears, though, are getting in the way of your ability to plan for the future, your quality of life, then that's where we're kind of looking at, intervention being really helpful. So cognitive therapies, and as you highlighted before, Annabel, it's really treatable. A lot of the therapies look at shifting your focus and being more present and mindful, and a lot of beneficial ways that aren't necessarily really intense. They can be short little tips and tricks for a lot of women, can be very helpful. But if it's really getting in the way and you're concerned about your level of fear, then speaking to your treatment team and seeing if they have anyone they recommend, a mental health professional or a psychologist who has experience in cancer. And if not, then your GP can also be a good point of call. But I'd say that speaking with your treatment team is often the first place to air these concerns and get that information that's evidence-based. So Sandra so-and-so told me that they quit orange juice, and et cetera, et cetera. Speak to your professionals and your clinical team and get the factual information that's appropriate to you.
That's such good advice and very memorable to Michelle. I think a lot of people think about what they put in their body in terms of diet, but that includes information, that includes feedback, that includes advice, that includes media coverage. And I'd like to apologize on behalf of all journalists for the times that we get it wrong. We're going to go now to, and buckle up, Belinda, because this one's coming your way. It's a question from Annette about optimized treatment and hormone therapy. Take it away, Annette.
Hello, my name is Annette. My question is about the optimization of hormone therapy. The side effects are quite severe, and I'd really like to know if there's any benefits to me in extended hormone therapy. Are there any tests available in Australia? Thank you.
I feel for you, Annette. Some people do really struggle with the hormone therapies with side effects. So I guess so hormone positive breast cancer, we do recommend hormone blocking tablets, and traditionally that was 5 years of tablets. And then there's been studies coming out in recent years showing that for some people, taking those tablets for longer, like 7 years or even 10 years, is going to further reduce the risk of the cancer coming back. However, not everybody with hormone positive breast cancer needs to be on tablets for 10 years. It really is the high risk people. And so I'd be saying to Annette to really go back and talk to your oncologist about what your individual risk of the cancer returning is and what the benefit of you staying on the tablets for longer is, because it may be that the benefit is so small that it's not worth the ongoing bad side effects, which it sounds like you're experiencing. The other thing is often helpful is just to take a break from the tablets for a little while and see how many of those symptoms improve. And then you really have a good idea of what are the side effects from the treatment. And then that helps you then work out, when you know what the benefit is for you, are those side effects worth the 1% or the 5% benefit of the extended treatment? So I think there's a few things that you could certainly talk to your oncology doctor about and work out what's going to be right for you, but maybe the longer duration tablets isn't going to be right for you.
Great, thank you for that advice, Belinda. We have another non-video question. This one's from Victoria. Now, she wants to know about options around aromatase inhibitors, and could you speak on the options available to take a break in treatment, and might this be considered an optimized treatment approach? Could you also just, this is for me, Victoria I think already knows, but I don't know what aromatase inhibitors are, so could you just quickly furnish us with that insight as well?
Yeah, so when we talk about the hormone blocking treatments, there's two main types. There's tamoxifen, which is a tablet that's been around for a very long time, and it works by essentially blocking estrogen uptake. And then the aromatase inhibitors are, well, a newer class, but they've still been around for many years, of hormone blocking tablets. And what they do is they reduce estrogen production. So they lower the level of estrogen, whereas tamoxifen blocks the uptake of estrogen. But they're both used to treat hormone positive breast cancer. They're both really effective in reducing the risk of cancer returning. So the aromatase inhibitors have a lot of side effects like menopause symptoms because they work by lowering estrogen. So a lot of people struggle with hot flushes, achy joints, joints, brain fog, vaginal dryness. There's a lot of symptoms that they can cause. And so for a lot of people, if they're struggling, I would certainly recommend taking a break to have an idea. Like I said a minute ago, sometimes it's hard to know what's the tablet and what's not. So taking the break and working out what is the tablet. Breast cancer trials were actually involved in a trial some years ago now where they were looking at intermittent endocrine therapy. So people had taken their tablets for 5 years continuously. And then at the end of those 5 years, they were randomized into a study where they took their tablets for 9 months on, 3 months off, 9 months on, 3 months off for another 5 years. And they actually found that intermittent 9 months on, 3 months off approach looked like it was just as good as the continual dosing after the first 5 years. So there are some approaches like that coming out of trials showing that maybe there is the option of a break after that first 5 years. So that might be something that could help Victoria.
And Annette too. I mean, it's interesting. I guess we're all geared when a doctor tells us to take a tablet, we go, oh, I'm going to take that tablet, I can't miss it. That idea that you've introduced of it being okay to canvass the idea of taking a break, which can furnish you with a bit more information about what is to do with this medication and what is to do with your body changing or doing the stuff that it was going to do anyway. That's a really interesting thing. And I'm thinking there's probably a bunch of people in our viewing audience who will take that home and think about it tonight. Thank you. Now, I'm going to go back to Boon because there's some more questions that are relevant to you. We have one from Antonia. She wants to know about treatment differences between countries and why one country can prescribe different lengths of radiation treatment compared to other countries. Why is that?
I think these the variations in breast radiotherapy across the different countries. I think these variations are less pronounced now compared to, say, 20 to 30 years ago. And this is because of a number of very large clinical trials that were conducted overseas. And these trials have consistently shown that giving a slightly larger dose of radiation over each treatment over a shorter duration, say 3 weeks, is as effective and as safe as giving a smaller dose of radiation each day over a longer duration, say 5 weeks. And as a result of these trials, that breast radiotherapy of the shorter duration, typically around 3 weeks, is now considered a standard of care for many patients in many countries, including Australia, the UK, Europe, and North America. In addition to that, I think the more recent research has also shown that breast radiotherapy of even shorter duration, for example, over 1 week, could be as safe and as effective, but we're still waiting for longer-term results of this study. And however, the shorter course of radiotherapy may not necessarily be right for some patients. For example, for those patients who have had breast reconstruction, for example, the safety of radiotherapy of shorter duration is still being tested in a number of clinical trials internationally.
I would add to Antonia that I don't have any qualifications in any medical qualifications at all, but I have worked extensively around government, and I know that we would all love to think that all regulatory regimes around medical treatment are well thought of and evidence-based and constantly reassessed, but often they are not. And often the regulatory regimes around treatments, medicines in different countries can wildly vary. And that may be sometimes because they haven't been revisited for a while. Anyway, that's just my 10 cents worth. Let's get back to questions from our audience. Deanne has asked, again to you, Boon, this is a question that kind of addresses the anxiety that's at the core of so many people when they're moving into their treatment journey for breast cancer. She wants to know, is there a model that allows you to calculate your chance of survival by adding up all the combinations of treatments to help you make this decision with numbers?
Yes, there are a number of online tools that allow you to input the various, the parameters about your cancer and the treatment options that you may have, and then work out, what the reduction in the risk of recurrence and therefore improvement in survival with each of these additional treatment. And most of these tools or models for estimating survival really apply to the use of systemic therapy, and that is chemotherapy and the hormonal therapy.
When you say, Boon, that these calculator models are available online, are you talking about just Googling it and pumping everything you know in? And is that a wise thing to do? I'd also take Belinda's insights on this as well, because obviously old Dr. Google can have some deleterious effects, right? So I would like to hear from whichever of you is keenest to speak on how you safeguard your own.
Yes. I'm happy to have a start. Yes, I think most of these tools are really tailored for health professionals rather than the general public. I think that's important to understand, because most of these models or algorithms, they're built on a specific database, and every database could differ. And therefore, even if you input the very same parameters into each of these tools, you may end up with somewhat different. It shouldn't be wildly different, but it could be somewhat different. And also these numbers need to be placed in context, for example, whether a patient is suitable for a particular treatment or not. So I think it's really important that any modeling, any results of these modelings are discussed with the oncologist.
Okay, that sounds like a sensible precaution. Belinda?
Yeah, I'll just follow up on that. I mean, I agree with what Boon's saying, but I know everybody Googles everything at the moment. So you'll straight away Google, how long am I going to live for with my breast cancer? And the information is often very unreliable. So I think I would always encourage people to, if they are Googling it, bring that information in and ask the doctor, like, this is what I found on Google. And then you can discuss why that does or doesn't apply to your situation. I think some of those online tools that Boon was mentioning, people can look at them. There's one called Cancer Survival Rates. There's one called Predict. They are based on people. So Cancer Survival Rates is based on a big sort of database of people treated in the US, and Predict is based on people treated in the UK. But they sort of look at outcomes sort of 10, 15 years later. So you have to remember they're people that had their treatment 10 or 15 years ago. So they're probably not going to do as well as what people being treated today will, because we've got better treatments now. So I think often with those calculators, if I'm using them with a patient, I'll be saying, well, actually, this is what this is telling us, but you're probably going to do even better because these days we've got better treatments, and this is why I think you're going to do better than that. So I think it's always worth, if you are Googling things or using these calculators, to talk about it with your oncologist or your radiation oncologist, so that you can sort of say why this may or may not apply to you, because yeah, sometimes those numbers can look really scary.
Yeah, that's such a good point, I think, Belinda, and thank you for making it so powerfully. I think, you know, in the quest for certainty and information, you're kind of scraping the whole internet for something that might help to eliminate some of the confusion, but it's always worth checking with somebody who knows about you, who knows about your cancer, and who knows about, like, where you're at and where the treatment is at in the place where you live as well. Thank you, Boon. A final question to you. Where do you see research going in the future on this topic of optimized treatment?
I think the research on treatment optimization will continue. We're going to continue to apply any new understanding of the breast cancer biology and technological advances to improve personalized care, not just in chemotherapy, radiotherapy, but right across the entire spectrum of breast cancer, early detection, screening, diagnosis, and treatment. And a final point that I would make is also that all these advances are exciting, and I think our patients rightly deserve all these advances. However, given the constraints in healthcare resources, I think that our research would also need to focus on the equity of access of our patients to these novel therapy and technologies. Some of them could be very, very costly, and we need to consider what the social and the ethical implications of these new treatments.
Okay, that's a really important point too. Belinda, I'm going to give you a crack at this question as well. What are your thoughts on the future of optimised treatment in Australia and New Zealand?
Yeah, I echo what Boon has said. I think it's a really exciting time to be working in breast cancer. I think every time you go to a meeting, there's so many new things coming out, and a lot of it is about helping people have the same outcomes or better outcomes with less side effects. I think there's so many clever scientists doing lots of exciting things now where they're looking at sequencing tumors and measuring cells in the blood. There's a lot of things that are going to be happening, I think, in the next few years in breast cancer in particular that are going to be changing the way we're treating it. And I think it's going to become even more a case of, as an individual, you get your individual cancer analysed and you have an individual program for your treatment. So I think that individualized treatment is going to become more and more of a thing into the future.
Isn't that interesting? Okay, and I look, I mean, I'm a rank amateur in this field, but every time I participate in one of these sessions, I find out more and more, and I have to have my boob in a toasted sandwich maker all the time because I've got dense and difficult breasts apparently. And every time I do that, I think I'm finding out more every day about these babies. So thank you very much to our panel for being so generous with your expertise and with your life experiences and your insights. I think we've heard some amazing things tonight, and they're all about the power of finding out more information that's specific to you, and the security and peace of mind that replacing ignorance and confusion and fear with knowledge, the good that can do, not just clinically, but also psychologically. So first of all, can I thank Margaret for being so generous, not only by participating in the PROSPECT clinical trial and then persisting with Michelle, but also for sharing your story with us tonight. It's never easy to revisit difficult times, but you did it with grace and generosity. So thank you. And thank you to Boon, to Belinda, and to Michelle, who have really communicated some great information to us tonight. Thank you to all of you who joined us on this session. As I said before, it'll be distributed tomorrow. Please remember that Breast Cancer Trials is an ongoing supplier of intelligence and research in this field. They do look to the community to help support this important research. So if you or your family or friends would like to make a donation, you can do that on the website at www.breastcancertrials.org.au. And that is, as Michelle, I think, said, also a source, that website, of some great materials that can help you in your information gathering process around this disease. Thank you so much all for joining us this evening. I'm going to bid you a farewell.